Good evening, and thank you for joining us for this SSAT webinar. Tonight, we wanted to explore issues related to healthcare systems and policy and how to best leverage the system to improve your practice. We have 4 outstanding speakers with decades of experience in navigating these issues. I'll turn to Dr. Arrington to introduce the first speaker.
Thank you. Our first speaker is Dr. Sharon Weber. Dr. Weber is at the University of Wisconsin, and she's going to speak on merging academics with clinical practice. Dr. Weber, you're still on mute.
Thank you so much. Welcome, everyone. I hope you can hear me now, yes? Delighted to be here tonight with such a fantastic panel of speakers and what is a really great panel. So I thank the moderators for inviting me. And I want to talk just a couple things about how to sort of best work with the academic health system to integrate your clinical practice and maybe even to find places to have a win-win between academics and clinical practice. Clearly, we all understand that there are many conflicts, and obviously at the top of this is that clinical productivity remains the driving mission for health systems. And one thing I think COVID has clearly shown us is that we have to support that financial bottom line. If the health system falters financially, we all do, and we can't do the academic work that we so value. I think it's also difficult because compensation plans vary widely, and sometimes the lack of presence for academic compensation for academic work is lacking. I think there's also some difficulties when the health system is pushing the leaders for clinical productivity, but the faculty is really invested in the academic mission, and this goal misalignment can create difficulty. Within any group, I think the faculty have varying academic missions, and they have different requirements. When you think about all the different types of research that faculty can do, there are different demands on time, travel, the size of one's team, what are the funding opportunities. And sometimes I think that it's the lack of transparency regarding understanding what your colleagues are doing that can create internal conflict. And then so just that sort of failure to recognize that each faculty has their own unique demands and to really understand that we're each dealing with our own struggle between this academic and clinical interface. Luckily, there have been some movement forward in the last many years, and this is a lovely paper from Chuck Scoggins and Kelly McMasters that showed really the clinical transparency when given in the form of a physician scorecard looking at clinical work and RVU transparency to different members of a department could in fact result in increased productivity. And so I think generally over time we have moved in the direction of more transparency, and I think that's fantastic. I think in addition to this, compensation models now tend to find some way, most of them I think, to support the academic mission, whether this is an academic RVU credit or using a point system. There are many different ways to do this, but I think recognizing that time that's required to support the academic mission and building that into a compensation plan is really important. I think there are, of course, a lot of conflicts, but there are also many places where wins can occur. And this is about goal alignment, really, between the health system and academics, and to think about how you can set yourself up to be in a position to leverage the health system to enhance the academic mission. And so this is just giving a few examples, and I'm sure the great group of speakers we have tonight have many of their own that we can talk about at the end. But I think some of these things are really pretty simple things, like trying to really understand what are the health system priorities, which can vary from place to place, and how can we leverage them to support our academic goals. And one quick example I will give is that the hospital was very invested in our hospital, UW Hospital, in a transitional care program. This was an area of active research, interest, and funding on my part. And so my entire team sort of rallied around this and leveraged these resources provided by the hospital in the form of nurse support for the program to do a protocolized adaptation, which we wrote about, and then to roll out a surgical transitional care program. And there's just no way with the funding that we had at that time that we could have done that without the support of the hospital. And so it just is one example of how to leverage the health system priorities to help enhance the academic mission. I think leadership opportunities are another way to do this. And clearly there are many reasons to love getting into different leadership positions, including the ability to mentor others to help them sort of balance this academic clinical interface, to be able to build a program that has your imprint, obviously very important, but then many opportunities across health system, department, and the medical school, if you are allowed into a leadership opportunity to build research opportunities into that. And one example I have is several years ago, our hospital was supporting a patient experience officer, which one of my partners was awarded that position. And she was very invested in the patient experience, had a whole team around her where the hospital wanted to get data around what was impacting the patient experience. And she utilized this team to provide that data to the hospital, but also to publish on that. And just one very simple and easy example. Obviously, clinical program development is clearly a mutual win for the health system, anything that's bringing in increased clinical volume. But there are ways to do this in which you can also enhance the research opportunities. And one simple example is we just recently opened up pancreas cancer prevention clinic in the middle of COVID, unfortunately. But in doing that and knowing we were starting a new program, we leveraged the EHR to build these sort of discrete data elements so that we could easily capture that, look at that data, be able to collaborate with other centers who were capturing similar discrete data, and that will be markedly more sustainable than trying to rely on a database manager, which I think is very hard to justify paying for in the year we're living in, and especially with how much we're paying for the electronic health record. So I think one thing I would think is to just really important to look at what are the strategic goals of your health system. And these are, obviously published somewhere. Think about what is the health system doing to align themselves with these goals, and how might I leverage these areas of focus to enhance my own research and academic goals. Couple things to move really from looking at the health system academic clinical interface, but to think about how to manage the demands on one's time, which I think is very, very difficult. And it gets to this concept of practice efficiency. This is a matrix called the Eisenhower matrix that I find really interesting when you're struggling with how do I get through all these things I'm supposed to do. And it's just an interesting way to conceptualize this, thinking about tasks that are important and urgent are things that you should do. And then just looking at whether it's not urgent or not important, and when you can delegate, when you can have the nice time to plan for the future, and thinking about the tasks that you can get rid of, because it's really easy to have these tasks just keep coming at you and not be able to offload some of them. So this is just, I think, an interesting way of conceptualizing, looking at what is really an overbooked schedule for most of us. In addition, really utilizing the resources that we have, and whether that's admin support, our nurses, or our APPs, like really allowing people to function at their highest level enhances their job satisfaction. Being able to delegate and offload some of these tasks so that you can have time to focus on the things that are really important to you, I think is also really important. And I think it's also really important to think about the fact that your priorities change over your career. And at any given point, whether it's early or middle or later in your life, thinking about, is the time and energy devoted to a given task aligned with what is currently important to you? And this kind of also gets to this concept of, really over the course of your career, you can have it all, but it's very difficult to have it all at one time. And just really trying to make a concerted effort to think about what are the things that really matter to me at this present moment. In addition, I will just say I've really grown interested in this concept of sustainability of career and how do we maintain that over time. I think carving out some contact-free time from work where you're not in the in-basket, you're not texting, emailing, available by paging, because I do think considering our career longevity is really important, and thinking about our physical health, our mental health, and the overall wellness needs, and making sure that we're giving those the time that they deserve. Early on, I think it's important to think about institutional strengths and what your institution might have at the table that maybe you didn't even realize when you joined. And then I was asked to talk about this idea about when to say no. And I just think it's really important to think about the overall impact of saying yes. We were always told you have to say yes to everything. And I think that is absolutely not true. And I hope that we will build a culture where it's okay to be more thoughtful in what we're saying yes to. So I think when you're asked to do something, kind of sitting back and saying, can I consider that and get back to you so you have time to consider whether this is going to make sense to you, keeping in mind all of these things. Does it align with your current priorities? Does it help you get somewhere for your future? There's always an opportunity cost to saying yes, and what the time that it will take you to say yes to this given ask is going to cost you somewhere else. So thinking about that. And then wanting to really give the task the time and energy that it requires. And I've been really interested with this idea of quality on time. Like, don't say yes to a chapter that's due in 2 weeks. You know you will never get there. When can you give a deadline to get a quality product out for whatever the due date is? I think also if you decide no is the right answer, asking somebody else to have that opportunity. Is somebody else available for that opportunity? And then I think a lot of people start to feel really struggling and overwhelmed, and asking for help when you need it in various forms is also really important. Other considerations for new opportunities, when you are taking on new roles, thinking about what you can offload that's currently on your plate, because I think it's really just not sustainable to keep asking people to do new things without being able to offload other tasks. I think there's a huge demand for institutional and local committees, and being a good steward in your health system, I think, is going to be recognized. Networking with others at your institution is also immensely valuable over the course of your career. And then thinking about our national presence, and these are critical duties for a lot of reasons, but clearly has the downside of time. But I do think if you talk to most people who are deeply involved in national presence, you're building with these contacts a team and a support network, and this is really important for maintaining one's longevity over the course of a career. Finally, I will say, sometimes we think about the health system and we think it's an us versus them perspective, and I will just leave you with this quote, which I love, which is really about understanding other people's perceptions and perspectives on the situation. And so just instead of thinking of us and them, to think about what the truth is might be, and what truth is in the middle. We must always seek the truth in our opponent's error and the error in our own truth. And I think this is just very valuable in thinking about how we can leverage the opportunities of the health system. With that, I will hand that off to the next speaker, and I thank you very much.
Thanks so much for that, Dr. Weber. Our next speaker is Dr. Pollack, who's a chair of surgery at Ohio State, and he'll further explore how to navigate the health system and address how to interface between hospital centers of excellence.
Great. Thanks, Victor. Can you see me and can you hear me?
Yes.
Great. Well, first of all, I want to thank Victor and Amanda and the SSAT for the opportunity to be with you tonight. And I want to thank Dr. Weber for that quote from Reinhold Niebuhr at the end. As someone who went to divinity school, I deeply appreciate a quote by an American theologist and ethicist to include your talk. I was really surprised and delighted to see that quote from one of my favorite theologians. So I have been asked to touch on tonight navigating the health system and the interface between hospital centers of excellence. So I'm just going to start off a little bit just talking about my experience here at Ohio State, which is, I'm sure, similar to many of your experiences, being at large, complex medical centers, maybe multiple hospitals in the systems, many beds, many different specialties, a lot of different facilities, being in complex departments of surgery that may have multiple divisions, multiple faculty members, lots of different goals and objectives that relate to different research objectives, education objectives, and things like that. It can be incredibly hard to navigate. And then you layer on top of that this notion of clinical integration and centers of excellence, and it can be even more complicated, especially if you're a junior faculty member trying to navigate your way through such a system, both from a clinical point of view, but then also perhaps also from an academic point of view or research point of view. So I would suggest that, for many of you who are at different medical centers, whether it be an academic medical center or a large multi-specialty private or semi-private group, to really get to know the organizational structure of your organization and your institution, and realize that there may be ways that you can seek resources, seek collaborators, seek colleagues, both within the Department of Surgery, but also outside it in these centers of excellence. So many institutions like our own are set up not only along departmental lines, but also along clinical service lines or centers of excellence. And these are coordinated, cohesive ways of trying to deliver patient care. They can be developed along different research proposals or research ideas, but typically as surgeons, we're kind of nested perhaps in a specific clinical center of excellence, whether it be a transplant, let's say, or GI or cancer. And the goal of these clinical care delivery lines are typically to amass different people from different departments to bring an interdisciplinary kind of group together to deliver high quality and efficient patient care, while at the same time providing opportunities to do high quality interdisciplinary kind of multi-department research. And the idea is to really kind of remove the departmental silos that may be typical of the traditional organization of medical schools or hospital centers. So as I alluded to, many of these centers of excellence or service lines are developed along a specific, discipline, whether it be cardiovascular, orthopedics, transplant, GI, or many places it's cancer. Many places have a cancer center that has a very distinct identity. And what these service lines or centers of excellence really are attempting to do is, create centers of excellence and high quality that will drive clinical volume, not only locally, but regionally and nationally. They're also ideally designed to create some operational efficiency, because as I'd frequently say that, as an oncologist in the Department of Surgery, frequently I have more things in common with the interventional radiologist and the medical oncologist than I may have with like my trauma surgeon, right? So many of us, if you're in vascular, right, you may have more in common, both from a clinical point of view and a research point of view with other people in the cardiovascular space than you may with the general surgeon who's in the Department of Surgery. So it's trying to create this like operational efficiency. Also some financial viability to create more cost-effective care delivery. So you have to imagine that any decision that's made in these service lines need to take into account not only the needs of the department, but also the needs of the entire service line. So for example, as a departmental chair, it would do me no good to hire like 3 or 4 more breast surgeons if we didn't have the pathologists to support them in the breast program, or if there wasn't enough, imaging faculty or imaging facilities to support that number of new breast surgeons. So thinking about things along service lines or centers of excellence creates a much more interdigitated and comprehensive way of figuring out what's best for this specific disease-based program that kind of supersedes a departmental point of view. And all of this hopefully will lead to that service line being a market leader, and then most importantly, delivering the best care for the patient, and perhaps also providing you as a faculty member another home, if you will, for your career research endeavors. So, there is this interface between the different hospital centers of excellence. And in my mind, the interface can be quite collaborative between the different centers. So I see a kind of interface between the different centers. There's also an interface between the centers and the different departments. So I interact with the leaders, the directors of the different centers of excellence or in service lines at Ohio State as chair. The different service line directors interact with one another. And then there's a whole nother interface that occurs with the hospital system. And when we approach the hospital system for resources, do we go to them as a department? Do we go to them as a service line? Does the department get on the same page as a service line leadership so that we can come up with a much more compelling and comprehensive ask of the healthcare system when we need resources? And I think this is particularly germane for even junior faculty. It's not just something that's important to, a leader if you're a division chief or a departmental chair, but if you're a junior faculty member and you're looking for resources, it's important to realize that, you might appeal to your division chief, you might appeal to your departmental chair, yet it also may make sense for you to reach out to your service line leader. And if you're a surgical oncologist, there may be resources that you can obtain for your academic and professional needs outside of the department from the cancer center directly, or the transplant center directly, or the GI program directly, or the cardiovascular center directly, that they may be more interested in providing you because the type of research and the services that you are interested in providing align more strongly with their key objectives, which is to further the pursuit of clinical care and research in that specific discipline. So I think it's important to have some strategy when thinking about where you fit into your medical center, both from a department point of view and from a service line or a clinical center of excellence point of view. And when thinking about integrating care across the hospital centers, to drive this market share that I discussed or improve quality of patient care delivery and research, as well as driving down costs, it's important to think of some key elements, and I've highlighted several of these here, which is to think about, positioning your service line for growth, right? Hospitals are more likely to devote resources and funds and investments in service lines or programs that they think will grow. And typically those things that have the most likelihood of growing or getting more traction is those service lines or projects that have some element of differentiation, either a specific procedure that maybe no one else in your market is doing, or treatment of a rare disease that no one else in your local market is doing. I think it's important to have a physician-led governance structure and to make sure that the decision-making and governance are aligned with the organizational goals of the healthcare system at large. And for you as a junior faculty member to fully understand what is the governance structure of the centers of excellence or service lines, so you know who you should be approaching for different resources and different opportunities within these service lines. And then make sure that you're equipped with data. So, these decisions are going to be data driven. So it's important to know, what the opportunities are, maybe what the market share that you currently have. If you're trying to build a program, understand, what it may take, what's the value proposition, and what's going to be the return on investment. And that's going to take you doing some legwork, looking at your market, and then also doing some cost analysis and getting your hands on some data. And typically some great resources to do this would be the marketing team at your hospital, and then also perhaps your business manager, either in the service line or in the Department of Surgery, who can help put together some of these pro formas for you. And then also, as I mentioned, make sure that you engage clinicians and researchers outside your Department of Surgery within these service lines and centers of excellence, so you can broaden your web of mentorship and influence at the medical center. And then I wanted to just touch on the funds flow, on whether it's good or whether it's bad. At the end of the day, I typically say things are either about relationships or they're about money. And so it's important to know how the funds flow in your organization. Some of these centers of excellence or service lines are very virtual in nature. It's very matrixed. And the service lines themselves do not have decisional authority around expenditures and revenue. So they do not function as revenue centers or cost centers. And so they do not have perhaps the discretional authority to give you funds or resources in the form of like startup packages or pilot funds and things like that. So it's important to understand what the relationship of these centers of excellence and service lines are with the hospital and with the practice plan, so you can understand how the funds flow and how revenues are distributed. Along with that, it's helpful to understand these clinical care models as we're moving more and more into quality incentive payment programs, how some of the shared savings are distributed amongst the hospital, the practice plan departments, and some of these centers of excellence would be important to know. And then understand the operational and clinical KPIs. So that's the key performance indicators. Truly try to get to understand, what is the true north of leadership, and what are their key performance indicators, and how can you align your research and clinical program with their strategic goals. So this is, I think, my second to last slide here. But I think some tips are, make sure you assemble a team that spans many different organizational entities, departments. Define how funds flow in your organization, and understand what the vision and strategic goals are of leadership. I think that service lines are helpful in breaking down silos and eliminating sacred cows that may exist at the department level, but get broken down when we're working more collaboratively across departments in a service line approach. And then, as I mentioned, make sure that you collect the data to really understand what the current state is, so that you can find out where the true needs exist, and then address those needs, and then follow the money, right? Really have an understanding of how funds flow in your organization, because if you understand how the funds flow, you will be much more successful in understanding who you need to approach and when you need to approach them in order to garner more resources for your clinical and research programs. And I think ultimately, as a junior faculty member, that's what you probably need the most of is, resources to launch your clinical career, to launch your academic career, and understanding not only the departmental structure, but also the structure of these clinical centers of excellence and service lines will serve that purpose. So again, I'd like to thank Amanda and Victor for this wonderful opportunity to present tonight at the SSAT webinar, and I look forward to a robust conversation at the conclusion of our other speakers' talks. So thank you.
Thank you, Dr. Pollack. Speaking of robust questions, and if any of the attendees have any questions, please put them in our Q&A icon at the bottom. Our next presenter is Dr. Stephen Stain, who is the chair of the Department of Surgery at Lahey Hospital Medical Center. And we asked him to speak on the give and take negotiating within the healthcare system. Dr. Stain.
Let me see if I can can you see my screen yet or not yet?
Yes, we see your screen. It's not in slide and presentation mode yet.
Let me see if I can make that work. No. Worked so well before.
Not yet.
Let me stop sharing, trying again. 3, 2. Not sure. Amy, can you?
Dr. Stain, I'm going to take control of your screen for just a second and I'll fix this for you. All right.
Thanks.
I just sent a request over. You may have to approve it. Perfect. Hold on. Okay,
Is that okay?
you are all set and I'm giving you back control now.
Well, thank you. I apologize. I was so nervous. I came early on to try it out and I still messed it up. I first wanted to thank the SSAT for putting this series of webinars together. I know when it was planned a year or two ago, we weren't sure if it was going to be successful, but it's been a very good amount of information to be shared by leaders. So my assigned task was about negotiation, and I think it's interesting because I have over the 30 some odd years of my career learned a lot about negotiation, and I thought I would approach this by talking about the people who've really shown me. So while my task was to talk about the health system, I think some of the principles about negotiation transcend just whether you're talking to your department chair, your hospital CEO, your chief medical officer, your division chief, or your dean for some reasons. And I think it's important to first stop and recognize, what are you trying to accomplish? Are you trying to get some more resources for yourself or for your group? I think many of the people on the call may be at the more junior level, but as you go through your career, you may have the ability to negotiate either for a service line, your section, your division, or at some point for your whole department. As Dr. Weber said, clinical volume is still the key. And many institutions, especially health systems, may be more likely to respond positively if you can show that it will increase volume, the request you're making. While I don't have an MBA, and I'm not necessarily saying you need to get one, but you need to learn how to understand business plans and be able to tweak them to get to show what is necessary to make the people give you the resources. It's also very appropriate and very needed to make requests for your academic career. And ideally, some of what you're asking for will meet the vision of what the institution would like to be. And lastly, I think if it's to improve patient care, that's also a laudable goal, which you can outline an ask for, and often, we are about taking care of patients. If you improve patient care, that's something that can also be successful. So if you're a section chief, you may be negotiating to hire someone new to join you or a partner. It may be your middle of your career and you're a flight risk and you're trying to negotiate a retention package. And as I say, research efforts, though we sometimes overlook them, I think that in certain institutions, hopefully in many institutions, if you can articulate a plan that will pay off in academic productivity, whether it's education of residents, participation in research projects, or funding, those are all very valid and viable things to request resources for. It's important to understand, I've had 4 jobs in my life. You may say that's because I can't keep a job, but I think that every institution has a different type of flavor and a mission and what they're trying to accomplish. There's some places, I would say when I was in Nashville, Meharry, it was primarily education. There's some very research intense institutions that really value the activity that you can produce by obtaining extramural funding. And for many, I think the clinical mission is what drives and pays for all of it. So one of the things I've learned is to watch people, and that's to watch and learn from people who've been very, very successful in getting resources. So my first job was at USC. I was there before Tom Demester, and he was chair for 10 years while I was there, and I learned a tremendous amount of things from Dr. Demester. He was a tremendous builder of program, was able to recruit people. And I'll tell you one of the stories about how negotiation. So he was able to transform USC Department of Surgery from being mostly general surgeons who did lots of different things to being specialty specific. And he spent a year, believe it or not, a year meeting in the basement of his house in South Pasadena, working on a plan. It was called a plan. We all got a copy of the book, and it was to subspecialize the department. But part of this was getting, what's a world-renowned trauma division funding. And at the time, in the 90s, the County of Los Angeles gave USC about $75 million for the clinical care of patients at LA County Hospital, and also paid for part of the faculty, but it was still not enough money. And what Dr. Demester negotiated was to have separate funding for the trauma program. And you may ask, well, how did he get, they had a trauma program before, it didn't get busier when he asked for money. But what the quote I'll ask you to remember is that he told the County of Los Angeles is, just tell me what days do you want me to have people take call? Monday, Wednesday, Friday. For what you're paying us, we can afford to cover 3 nights a week for trauma call, and we just don't have enough funding to be able to attract the faculty to do that. So if you learn from that story, Tom knew what resource he had. He could provide, and recruit very qualified trauma surgeons to care for patients. And trauma was still a big part of the LA County program. But he also understood that he had leverage over the county, and that eventually led to additional funding, stipend for people to take call, and the ability to recruit and retain some exceptional trauma surgeons. I know Victor was in Nashville in the early 2000s, and one of the visiting professors was Courtney Townsend, who's become a very, very good friend and a mentor of mine. And when he gave his grand rounds, he took Dan Beach and I out to dinner. And one of the things that he told me is that you're unlikely to change an institution. So, so as you think of the institution that you're at, what really makes it drive? What makes people get promoted, not just academically, but go up the academic ladder to become section chiefs, division chiefs, chairs? Are they hiring people who are primarily clinicians who bring clinical volume? Are they individuals that will bring research expertise? So while you may want to go to a place that is very research oriented, but if you're at a clinical place, it may be you may be less able to get the resources that you are requesting. The third person may surprise you. John Maupin was the president at Meharry Medical College. He was a dentist. And one day after I'd been at Meharry about two or 3 years, he called me in and he told me I was like a bull in a china shop, because I went in and just demanded things and didn't really know how to get things done. The things I learned from him is about committees. There is a committee dynamics, and what he told me to do was to, before the meeting actually started, you need to go lobby people to your side of the decision. So you came in, and at the time the meeting actually happened, if there was a committee that was going to make a decision, whether it was about starting a program, whether about hiring somebody, you should try and have the votes before the meeting actually starts. And that's something I still try and do. If I know there's going to be a controversial thing that's going to come up at a committee meeting where I'm asking for something, I generally have talked to 4 or 5 people and got a sense where they are and try and answer their questions beforehand. If it's an individual person who's going to make the decision, like your dean or your department chair, the best way to get to influence them, before you ask them directly, have a sense of who they listen to. And you may be successful in trying to talk to one of their longtime colleagues or a different department chair or something about, to explain to them, not just you doing the explaining, to hear it from a different vantage point, why what you're proposing might be good for the institution. As has been said before, this is an article that came out a couple years ago in Academic Medicine that talked about how different academic medical centers function, written by an orthopedist named Vincent Pellegrini. And the traditional academic health center has a medical school of faculty practice. The money mostly comes from the hospital, and we should recognize that. And where you impact your requests, whether it's the faculty practice plan, the medical school, ultimately much of the funds that are going to pay for that come from the hospital. And in health systems, whether it's an academic, an affiliated, an integrated system, or really a corporate system, who makes the decisions really differs. And in some places, the dean, where I'm currently, we have a president and a CEO, but actually financial decisions are actually made by the chief operating officer. So you need to know and understand who has the authority to make decisions and be able to impact the system at the place that actually has the ability to make a financial decision. And I would just say, trying to learn what that is at your institution, and it's worthwhile, looking at people who have been successful and seeing how they have been able to get resources. One of the things you should take stock of is, what is your value to the organization? I know when our busiest joint surgeon comes in and asks for something, he already brings in a lot of funds for the hospital. So if you can identify what you do for your department or for your hospital, is it primarily clinical? Are you a prize recruit that they brought in 3 or 4 years ago and they want to keep you? Are you really changing patients' lives by your clinical care or by the collaboration you do with others? I think it's very, very important to know your value and try and enhance that value before you make a big ask. If you're going to go into a meeting beforehand, prepare. Often what I do is when I'm going to meet with my boss, I have written out what I want to do. If it's a big request, I will have sent to him ahead of time a plan, so he's not just reading it cold. And realize what you asked for may not happen in one meeting. It may require an introductory meeting, some follow-up meetings to figure out what questions he or she may have. And then when you ask for things, ask for specific requests. Globally saying, I want to increase pancreatic cancer surgery may not be he or she may not be as receptive saying, I want to develop a pancreatic cancer clinic that's going to require a physician's assistant, 2 nurses, and we're going to have these outcomes. You need to be able to project what your increased volume is going to be, whether it's in clinical operations, whether it's in research grants, but be very, very specific. Don't leave it for your supervisor, chair, chief, section chief, to figure out how to do it. Be prepared with solutions that are actually quite specific. and that will give him or her the chance to evaluate and come back with what he or she can do or cannot do. One of the things to always remember that is that, you know, all of us who have people report to us, when they're successful, we are considered successful. So don't ever forget that the things that you do that may help yourself may also help your chair or your division chief. And I'll close with the last slide is that, you know, really the goal of all this is to get to where you can be at the table where decisions are made. A quote from Al Capone, you're either at the table or you're on the menu. Thank you very much, and look forward to the question and answer session.
Thank you, Dr. Stain. Our next speaker is Dr. Hesslin, who is currently the director of the University of South Alabama Cancer Institute, and he will talk to us how to be a good surgeon citizen.
Right. All right, so same thing. Let me see if I can make this work and share here. Share. How do we do? And then we'll go to presentation mode. Or are we going to have Amy? I had hoped that I wouldn't be in the same boat as, oh, I didn't, as Steve. Are we there, Amy?
You are all set.
Great, thank you very much. My name is Marty Hesslin, and most of the data that I'm going to be talking about, I generated at UAB in Birmingham. I moved from Birmingham about 5 months ago, and I was able to just generate one slide with the USA logo on it, so you see it here, but after that, you won't anymore. So, what I'm going to talk about is mostly about the lowly critical conversation. You've already heard about the academic mission and how to make cash, and that cash is king. You've heard about centers of excellence and influence and who brings the money, and knowing those important facts as you develop around these centers of excellence. And then we heard from Steve that negotiating cash and influence is really important to your career. So today, for me, it's just talking about the lowly critical conversation, the part of it that is makes everybody feel uncomfortable. My background is that I was chief of the medical staff for 6 years, and I ended up, you know, it's essentially HR for doctors for 1,500 doctors and 1,000 residents. And the reason what I wanted to talk about is why you should care as a surgical leader and why this is really important, and then some strategies on the background before you have these critical conversations. And the one critical conversation, because there's lots of them out there, to focus on is you are a surgical leader and one of your faculty has some issues. And so that's what we're going to focus on today. The first slide is why should we care, right? I mean, who cares? It's not a big deal, but I think that the people who are delivering high quality care understand the challenges surrounding it. So as a leader, if you practice medicine, you're in the same boat as the people who are having these issues, and that gives you credibility. Secondly, if you identify and solve some of these systemic issues, you'll make the practice of medicine easier. Your faculty will like you more. And you as a surgical leader absolutely need to be involved for the management of the practitioners, because A, if we don't do it, this is a Murray Brennan quote, credit to Murray, if we don't do it and get involved in the solution, somebody else is going to do it for us and no one will be happy. Secondly, I think that when we talk about critical conversations, it always boils down to now that recognizing that burnout is important. We ask people for resilience is necessary, but neither are sufficient if the environment of care is not actively managed. And I just like everybody to focus on that for a second, because one of the things when you have critical conversations around event management and you're thinking about, well, oh man, I got to go talk to this person again. A, understanding the data is really important. B, we're going to hold everybody accountable to one code of behavior. But C, most importantly, you have to be their advocate. Because if you're going to dole out the call for accountability, you have to be the part of the person that says, I am also going to be your advocate. And we'll talk about that a little bit in the next couple of slides. So we did this as a peer review process, and I only want you to glean a few things from this slide because I showed up with 27 slides and Sharon Weber said, if you put that many slides up, I will never come talk at your institution. So I decided to cut it way down. Anyway, first of all, managing, I got to move this thing out of the way. Hang on a second. Managing a situation as a surgical leader is usually reported to you by nursing or medical staff leadership. One thing I would recommend is ask for the written version of the event report, because what you hear on the phone and what actually gets said or reported someplace can be two very different things. Secondly, ask your faculty to write down their side of the story and send it to you. It's extremely important. A, it's cathartic for the faculty. B, you get some insight onto whether they have insight into their own issues or problems, and you will identify an enormous amount of issues in the environment that will then allow you to help be their advocate. It takes a little extra time to do this. We set it up as a process across the medical center, and we're able to manage a whole series of events that involve the environment. But also then you can talk to people about how to manage stressful situations. And then ultimately you review both sides of the issue and sit down with your faculty. When we looked at an event, so we did a study that looked at 314 events around some type of event reporting. And we really divided into the event and the issue. And those are two things that you need to really try to understand as you talk to your faculty. First of all, when you look at this event, and this is particularly important for surgical specialties, first of all, 2/3 of it was an attending physician, but that means 35% or 1/3 were resident physicians. So critical conversations around event management is not only to attendings, but it will also involve residents. A full half of the events that we looked at over this 3-year period involve surgical specialties. So if you are a surgical leader, you will be involved in these processes. And why is that? Is it that surgeons are just aggressive or angry people? No, that's not it. The issue is that the land that we live in, right here, 61% of it involves the OR, the ICUs, or procedure areas for which we live in. So it's not necessarily that it's a issue of who we are, but it's the issue of like where we live and the stresses that are involved in the practice of medicine. This is another really important slide to understand as you set up to have a critical conversation. There are some people, and when you look at this slide, the way we interpreted it was that 76% of the time over this 3-year period, people had one event. And then when you went further, a full 24% had 2 or more. What we interpreted this is that this 76% of the people were actually trying to do a good job in the practice of medicine. And what turned out was that they were frustrated by the barriers that were put up with on-time starts, consent policies, issues surrounding paging in the middle of the night. There are all these things that we as attending physicians are often now immune to, but we don't understand it unless we hear back from the people who are actually on the front lines. The 24% is a different conversation because these are recidivists and often with personality disorders. The two most issues are arrogance and narcissism. Usually you can identify that, but not always. And those need to be managed a little bit different. That's the subject of a different conversation than the one we're having today. When you look at the events that people are subject to, the things, and this is just in rank order, unclear expectations, work overload, ineffective help, differences in medical practice, And we just go through and not rank them, but these are the ones that turned out to be the most significant. Hospital capacity and all those things put together, those are things that we can actually intervene on for our faculty. So instead of just saying, hey, you need to be a little nicer. Hey, I heard that you got upset at somebody. Try to understand their side of the story and how you can be an advocate for those people. Now, the interaction is also important, and this is just insight into how to manage people and what happens with an interaction, right? When you look at people that get reported, 71% of the time it was called a unprofessional communication, and the other half was no communication. I'd just like to take a second to talk about this, because unprofessional communication depends on the situation that you're in, and I'll show you that data in just a second. But when you look at unprofessional communication, when the reporter will often write down, Dr. Hesslin was yelling at me. But when you hear back from your faculty, the other side of it is actually, I was being direct because I was worried about the patient XXX problem. And so therein lies often the difference. Now, keep in mind that of 1,500 doctors, only 150 reports came back every year. So that represents an extremely small percentage. So usually there's something else there. And that's where, modification, behavior modification, and coaching comes in. No communication is over here. And that depends on whether or not you actually know what your physicians that are underneath you and the residents are doing. On one hand, it's unprofessional if you forget your beeper and you don't tell anybody. On the other hand, if you go ahead and have somebody that writes you back and says, no, I wasn't able to answer my page. I was covering 3 ERs. Someone was in the ER coding, and no, I couldn't get to that. Well, that's inadequate backup systems. And that's where you as a leader identify those issues and work with your hospital service line, whoever is doling out the resources, to make sure that your faculty are covered during these sometimes challenging situations. And this is a great slide. We didn't show up to, when we did this, we ranked clinical stressful situations between 1 and 10, 4 separate observers. And then we looked at the egregiousness of the behavior, ranked it 1 to 10. And isn't it biologic systems awesome? Because they both turned out to be relatively bell curves that map to each other. And what it shows is that the stress of the clinical situation is roughly equal to the egregiousness of the behavior. And what that tells us, that it's potentially actionable. Because if you believe that the environment is involved with the people's reactions, and we can affect that, we can change the egregiousness of the behavior and make it a better place to work for the people who are working there. Interesting concept. So one of the things you can also do is track your event density. So track it over time. We did that for everybody, but you as a leader can figure out where the hot spots are in your environment. This quote, egregious behavior or finger pointing, suggests there may be a hostile work environment. And initially, the intervention should be managed at the departmental level or in your sphere, but then co-managed with the hospital and unit leadership and the College of Medicine, especially if you're going to ask for resources, and then refer to Steve for negotiating, get cash and influence, and Sharon for how to make cash in the academic world for those resources. So this is one of my fledgling attempts at making clip art, and you'll notice it's a funnel. And what this is trying to talk about, things that you as a leader can work with your faculty to recognize the issues surrounding an event, and then you can help them understand it. So if you look at this, first of all, before you ever mention anything about the event, you talk to your faculty about this: prior interactions and reputation. Can't help you. If you have 10 double-digit event reporting, regardless of whose fault it was, it becomes unrecoverable because you can't work in that environment anymore, and that's a different conversation. So keep in mind that you don't want to become a target, and you do need to work in the system, but you need to work your faculty need to work in a situation where they can understand the environment. But then their personal trigger, you go from calm to frazzled, perceived egregiousness of the event. You go from, hey, it's no big deal, to, hey, help me save this patient's life. Or the immediate environment, so the last 24 hours, right? No calls last night, everybody's going home today, to, I need to clip a cerebral aneurysm in the governor's daughter, and it's my scrub nurse's first day. And then lastly, the external environment. My wife and family love Birmingham when I was there. To, my wife and family hate Birmingham and demand we move back to New York. So how do you manage that? First, these are the responsibilities in green of leadership. This is where you work with your faculty on self-awareness and strategy development for managing these stressful situations. This is, as Dr. Brennan told the story, that most people are at weaning, but it doesn't mean that people can't be aware and set up guidelines around it, or the perceived egregiousness of the situation. You can look at it and say, well, wait a second, maybe not everybody's dying, and it doesn't have to be a super inflammatory response. Secondly, evaluation of current responsibilities and personal goals. These are the things that we as leaders need to look at our faculty and work with them in these situations and having these critical conversations. Now, that's not enough, because the advocacy part comes from further investment in the environment of care to reduce these stressors, improve patient safety and satisfaction. That's working with your administration and negotiating all the cash, like Steve said. So, in conclusion, persistent efforts to address the behavior of recidivists should continue, and you should have those critical conversations, but that's really beyond the scope of this talk here. What we're talking about is that the change in the clinical environment for the betterment of the practitioners and the safety of the patient lies in the ability to you, the leader, identify the problematic areas and be involved, actively target these for transformation, and then, most importantly, deliver timely, fair, and focused conversations to help your faculty go forward. And I think that's it. Thank you all very much. Be happy to answer any questions. I think everybody else has got to open up.
Yes, sir. We want to thank the presenters today for our webinar. There are a few questions. We'll start out with a question from Dr. Hesslin, specifically for Dr. Stain, but for any other panelists that can give their insight. Approaches to resolve conflict or disagreement during negotiation without breaking down communication.
So I would say I may be the only one on this panel who has a temper, and I know there are certain triggers for me. If people approach me in a certain way, it's not gonna end well. So what I try and do is so if someone stops me in the hall and makes a big request for something, it really does. I need to prepare myself to be able to think rationally. So I think what I try and do is to make sure it doesn't end well is know if I'm going in a bad place, I get a feeling in the pit of my stomach, and just stop. I'm really not able to talk to you right now, and we'll probably have a better, I'll probably have a better understanding if we make an appointment and talk about it. Even though I know what I'm going to say, I just can't say it in a calm manner now. How I'm going to say no. but I think knowing yourself, the solution is to know yourself and know when you're going to go over the edge, and don't let yourself go over the edge, and put yourself in an environment that you can control in your office and be prepared how you're going to respond. That's how I would say. I'm sure other people have other ideas.
I think Dr. Pollack had something to say.
Yeah, I would agree with Dr. Stain. I mean, I think a couple things. One is never make it personal. So
It's that Ohio connection.
It must be. Well, I think he's stuck for a second there.
Should we move to a different question, Amanda?
Oh, sure. I had a question myself. If Dr. Hesslin or Dr. Weber wanted to contribute to the negotiation answer, I'll leave you at that. Oh, Dr. Pollack looks like he's coming back on.
Can you hear me?
Yes.
Oh, sorry. I don't know.
Can't see you, but we can hear you.
Interesting. Okay, can you see me now?
Not yet.
Can you hear me?
Yes.
All right, I guess my velvety voice will have to do. So I was just saying that, I think to getting to know people, so you have some context, you try to put a lot of relationship equity in the bank. So when you go to negotiate with someone, you can make a withdrawal, so to speak. And then typically, you want to figure out like, what do you need to be successful, but no one likes to hear the word I. So I need, I want, I this, I that. So try to figure out, you may want to be successful in your lab, but as a department chair, I want our department to go up in NIH funding or whatever it is. So you can approach it kind of like, Tim, I know your goal is to improve our NIH funding. To help you achieve your goal, I want to be successful in the lab. And in order for me to be successful in the lab, I think I'm going to need a surge tech, right? That's a very different way than coming into the office and saying, I need a surge tech. So I think trying to think about like larger departmental goals and the goals of the person you're negotiating with, and then embedding what you're asking for in that context can be more effective.
Thank you. Victor, did you have another question or you good?
I'll follow you.
Okay. Well, my question was, as hospitals become more cash strapped in today's environment, but they still want the academic mission. They still want the educational mission. They still want us to teach and do research, and we still want to do it. But they just don't have the resources to support other than increasing productivity. How do we work around that? Or how is that going, how is that going to be feasible?
Do you want me to go first, or Sharon, do you want to go?
You go ahead, I will follow.
Yeah, I think there are a couple different strategies. Everybody can't do everything every day. And except for at presidential presentations, nobody is actually everything that they say they are in those presidential presentations. That's just a big lie. And so I think what you have to do is realize, you can organize it any way you want, but for me, it's trying to get people that to recognize what's in their DNA and make sure that you encourage them to be one or maybe one or two things in their DNA. Like if you're not a basic researcher, you shouldn't be in the lab. And no matter what we encourage people to do and encourage them to be whatever fits in our model, we really have to ask people first, what's in your DNA, do that piece of it, and then be clinically active if that's what it is. The other thing is you have 5 people that haul it so that one person can be in the lab in your group. If you draw a box around that unit and say, listen, we are going to haul it. We're all going to be involved in the strategy. We're all going to be involved in the greater good for whether it's Tim's NIH ranking or the the financial viability of the unit. But then we are going to recognize that one person is going to work a half-day clinic and do half-day of outpatient surgery so they can haul it in the lab, and we are all going to be part of that greater good. Sharon?
Yeah, I will just follow that up with a couple things. One of which is, I think it's clear that the joy we have in going to work every day is being part of a team, however you define that. And if you have trouble finding who your team is, like find another place to recognize a structure in which you're coming to work and you're part of this team that's working together, like Marty outlined, because I think that is really the fun of going to work every day. That may be your division, that's fantastic if that's the case, but It isn't always that. It might be your research team or your cross-disciplinary cancer team. And I think I would just get back to answer your question, Amanda, about thinking about in which ways in moving forward the healthcare system can we leverage that to gain either education on the education front, the research front. I think there are many ways to do this, and we just need to think actively about it. And then when we're lucky enough to be in leadership position to help people get to those places that will help them meet their goals, the goals that they have at that given time, which will change over the course of your career, right? So I think it's just about being a mentor. It's about finding the right mentors. It's about leveraging the health system resources that are at the table at any given time.
So to follow up on that, how do, most clinical research programs are not funded. So how does one sell a clinical research program? And I think that goes for a few of the talks today, outside of the department. So does one go to the cancer center? Does one go to the dean? Does one go and really focus on the clinical mission of what the research enterprise might improve? Is there a different strategy?
I would maybe just kick it off by saying, like, to follow my prior comments, that might be a great way if you go down a QI pathway. We want to focus on patient safety and quality, and that ends up being a clinical question that can be investigated, and selling the idea that you are also mentoring other learners in doing this research, whether it's a truly QI project in which you can see a benefit towards improving patient care, or looking at patient outcomes. So there's an educational piece there, there's a research piece there, but I think the health system will love to buy it as a QI initiative frequently.
And just to add to Sharon, in our marketplace, you need something to be a differentiator. And as you differentiate yourself in whatever market you have, clinical research is one of the things, in addition to quality, that allows you to say that we are actually investigating the future therapies in the cancer world. We're investigating the future therapies. We are a part of a national presence, and these are the things that are differentiators for us. So I think it's also how you spin it, and then, as Steve said, how to negotiate and present it to the leadership in a way that they understand the importance.
Yeah, I definitely think it depends on the program, as Dr. Hesslin is alluding to, and Dr. Weber is. I mean, I think there is some value, obviously, to national recognition through research and podium presentations and things like that, especially if you're at a place that has a service line or a program that maybe hasn't had that in the past. So, if you're a proposition that you're going to do that by, publishing so many papers or getting on, the podium or things like that, then you may be able to get resources to do that. It is obviously tough to get sustainable resources for kind of unfunded clinical research. So I think that could probably work for a little while. It would be hard to imagine that it working long term. I know that some places have some element of this built into their compensation plan as kind of a bonus dollars for like papers or presentations or things like that. But it can be challenging.
But I think that, the first issue, if you're going to do clinical research, is getting a way to collect the data. And sometimes you can leverage what the cancer center has, or for quality issues. So then you add onto that, residents and fellows who will enter the data. So first getting the data entered, and I know there have been collaborations between a number of people, Kubi and Scoggins and those guys have written papers. They have a consortium of people who put data together to add to their sample. But I think they can creatively, but the first thing is, you gotta have a way to collect the data so you can be able to recall it for abstracts and papers.
Terrific. Any other questions from either the participants or? No? Well, I think looks like it's 1 hour and 16 minutes, so we're on time. Thank you so much for joining us. We appreciate it. Thanks for teaching us this evening.
And thank you to the panelists for presenting. Have a good night.
Thank you.
Thanks for our moderators. Appreciate it.
Yeah, thank you.